Two words: government monopoly. The median wait time between seeing your family doctor for treatment has increased from just over 3 months in 1993 to 10 months this year. What they don't measure, because they didn't think they had to, was your wait time to a family doctor, which has also increased by weeks. And right now there's 5 million Canadians who don't even have a family doctor. Consider too that the cost of public health insurance for the average Canadian has increased 100% since 1997. We spend 11% of our GDP on healthcare, more than 27 other comparable OECD countries. But among those countries, we're 31 out of 34 in acute care beds, 26 out of 31 in medical doctors, and 17 out of 32 in nurses. Emergency rooms across the country are routinely closed. Foreign medical professionals can't get licenses, and we have too few medical spots at universities. Currently, we have 1.3 million Canadians on a waiting list for a procedure, many life-threatening, and most recently, even the BC Supreme Court acknowledged that people are dying on the waiting list. In 1967, Canada was the world's 9th largest economy. Today, it's 17th. In terms of income per person, we've fallen from 3rd to 15th. Ontario is the 3rd most taxed jurisdiction in North America after Nova Scotia and Newfoundland. And Canada's GDP per capita is 1/3 less than the US. Since 2008, combined federal and provincial debt has doubled from 1.1 trillion to 2.1 trillion. That means that over 15 years, our debt to GDP has gone from 53% to 75%. Also consider you consume 10 times the healthcare you do after 65 that you do before 65. And over the next 20 years, the number of Canadians aged 65 and older is projected to increase by 50% to 11 million people. Ladies and gentlemen, we don't have a healthcare system, we have a queue system. And we're out of money, caught in ideological dogma that has resulted in us having one of the worst performing healthcare systems in the world. Every system in the world that is superior to ours has a competitive, private alternative to the universal scheme. If Canadians want a world-class healthcare system, then they need to think world-class. Competition will ensure that we get there. There's absolutely zero incentive to deprive patients of the best possible care, right? That's it. In fact, at the public system, if you have an issue, which we have many times with some major hospitals, there is only one hospital. You're not, there's not another hospital to go to other than Toronto General, right? It's all, there's such a limited amount of resources that you really aren't as accountable in that public sphere in our system. There's no other system in the world that looks to Canada as a model. Every other system that's superior to our system has some mix of public and private providers and public and private insurance. There's simply not another example for Canada. And they have superior healthcare systems. So that's really my single point. We need to look at how other countries do it and find our version of that. And they struggle with the same issues with supply, acknowledging that, especially after COVID. But no one is saying, you know what, the answer to that is to create a Canadian-style monopoly. Do you know how we get a referral in Canada? Your family doctor faxes the specialist. All of those countries, and let's look at Asia as well, Japan, Singapore, there's so many countries that have a mix of public and private insurance and public and private provision. And you can be a not-for-profit or a for-profit and still compete. In fact, when they compete, both get better. So this idea that you only can have one or the other, or one overall monopoly, I think is a total fallacy, because we're the only ones doing it. And if we keep doing it, we'll be back in this room 4 years from now, and I'll have new stats, more debt, more waiting lists, still faxing. When you look at all of the best healthcare systems in the world, the alternative approach is activity-based funding, or having money follow the patient. The developed world's highest performing universal access healthcare systems all employ private providers in the delivery of universally accessible services and they have activity-based funding for hospital and surgical care. They also importantly require patients to share in the cost of their healthcare, with exemptions for those in low income and the chronically ill, among other categories, to make a more informed decision about when and where best to access the healthcare system. Cost sharing reduces the demand for healthcare services and leads to a restructuring of a patient demand based on the cost of services. These top-performing nations also allow all patients to seek care on their own terms with their own resources, when they wish to do so, recognizing this reduces demand in the public scheme and allows individuals an alternative when the universal system is unwilling or unable to meet their needs. A private health insurance market would reduce wait times for most, if not all, Canadians based on the experience of all other developed nations with a universal healthcare system.